And I'm going to start my summary. Got it. Okay. All right. Well, welcome everybody. Nice to have everybody here for our weekly meeting, but we're our monthly guest. We're fortunate this week to have with us Danielle Frain. She works as a physical therapist at Sarasota Memorial Hospital, the Rehab Pavilion in Sarasota. So we're looking forward to having a discussion about PT and PD. So with that and said, Danielle, maybe you could introduce yourself a little bit. Tell us a little bit about your current position at SMH and how long you've been there and what do you do and all that stuff.
Yeah, first of all, thank you, Roger, for having me. And I think it's really amazing whenever people can be involved in community-based support groups because it makes managing a neurologic condition a lot easier when you have a team. And so thanks for hosting and thanks everybody else for being here because that means that you want to learn and you want.
Oops, I muted you by accident. Sorry, Danielle. My bad. Sorry about that. Pushed the wrong button. I'm sorry.
Okay. Am
There
I
you go.
back? I'm
There you go.
back.
You're back.
Okay,
Sorry about
cool.
that.
So yes, anyways, I am a physical therapist and I work at Sarasota Memorial Hospital in Sarasota, Florida. And I work in the outpatient clinic as a part of the rehab pavilion. And I mostly treat people with neurologic conditions. I've been here for almost 7 years, and so it's been quite a journey with our neuro program. Quite a bit of development has happened over a period of time, and I am also LSVT Big certified and certified in the Power Moves program as well.
Nice. Awesome. Awesome. What made you decide to become a physical therapist, if I might ask?
So it was process of elimination, actually. So 18-year-old Danielle, I had no idea what I wanted to do with my life. And so I started out in engineering, and no offense to the engineers, but I am not one of those. I couldn't think like the engineers are required to think. And I also did not want to sit for a living. A lot of engineers have to work on the computer and crunch numbers, spreadsheets, all of that. And I didn't want to be sedentary for my job. I wanted to move. And so what I did is I pulled out the list of majors at the University of Florida. And there was a list of about 200, and I started crossing things off. And so I landed on exercise physiology or exercise science. I knew that I had a passion for exercise and physical activity. And then I also knew I wanted to help people. And I went on to get my doctorate in physical therapy from the University of Florida as well. Go Gators. And I am very blessed to be a part of my profession.
Nice. Now, so when you got into physical therapy, though, you ended up branching off to become specialized in neurological disorders. What made you move in that direction?
Each physical therapist graduates with a generalist type of degree. So then, based on where we practice and where our interest lies, we get to tailor that practice area. And I knew that I would be bored with treating neural or orthopedic issues. And so I was like, okay, I don't want to do that, but where else could I go? And at Sarasota Memorial, there were just a lot of doors that opened that landed me into this position. And I have come to love the nervous system. And I really love the challenge that it presents every single day. So I'll get two patients that have the exact same diagnosis, and they can be completely different in their presentation. And so that challenge that you never know what you're going to walk into, that's the piece that I needed. And so I get to help promote changes to the nervous system.
Yeah, I got it. Okay.
And
Thank
so
you.
those changes to the nervous system is called neuroplasticity. I hope you all have heard about neuroplasticity, but it's our ability for our brain and our nervous system to make new pathways. And so through task-specific training, through lots of repetition, lots of intense practice, we can make those changes and then improve function and the ability to perform usual activities. So I'm a bit of a scientist, and I love working on the nervous system.
Oh, nice. Yeah, we actually
Yeah.
had talked about in the previous some previous meetings. We talked about a book all about neuroplasticities. It really is amazing how the brain can rewire itself after strokes or traumatic brain injuries and things like that. Even with, like I said, with Parkinson's, that's interesting.
Yeah.
So there are a lot of myths in the Parkinson's community. A lot of people say, you shouldn't take carbidopa, levodopa until you absolutely have to. But there's a lot of myths, and one of the myths that goes along the lines of what we're talking about with you today is about PT. A lot of people say, oh, no, you don't need to go to see a physical therapist until you're starting to have problems falling or tripping or getting out of bed. When do you feel that someone who's diagnosed with Parkinson should see a physical therapist?
That's a great question, Roger. I am what I consider an evidence-based practice clinician. So that means that I take what our research supports and I make clinical decisions based on that. So part of my conversation with you all today is based on information from a review study that was published a couple of years ago. And I shared it with Roger, so I don't know if he can share it with the group, but it essentially, there can be emergence of non-motor symptoms of Parkinson's. So when I say non-motor, I'm talking about sleep changes, mood changes, changes in smell. They can emerge 20 years prior to onset of motor symptoms. And that is like an amazing stat. And so you can have degeneration in your brainstem, and this is 20 years prior to those motor symptoms coming along. And so eventually the changes in the brainstem will then progress to changes in the basal ganglia, which is the center of the brain where dopamine is produced. And so when we talk about, well, when do we get into physical therapy, occupational therapy, speech therapy? I tell people as soon as possible. As soon as you find out that diagnosis, I want you to come see us. And so some other interesting information from that article is they had reports from even people with mild disease severity had changes in their ability to perform their day-to-day activities. 25% of them had changes in their walking. And so these are all people that need to get in to see a specialist who can evaluate their movement system and determine what can we do to help that. There was another study that of 100 people newly diagnosed, and 26% of them reported falls prior to their diagnosis. And then 80% reported falls in the next 4.5 years. Like 80%. That is so amazing, team, that number is so high. And so unfortunately, like falls are really common, but they're also a big determinant of like morbidity, which is like injury, or mortality. It can even cause death. And so like, we don't like to talk about those things, but you have to talk about it. You have to come and see a therapist for screening for falls. And then the therapist can help determine a program that will help you prevent those falls. Because I have people that come and tell me, oh, I don't fall. I just kind of catch myself and I'm fine. Or other people, they're like, well, I kind of slid to the floor. Anytime that you have an unplanned meeting with the floor, it's not a good day, team. And so that's what I really want to stress to people is I want you to be aware that that can happen, but know that it's also preventable by changing what you do in terms of your habits. Maybe using an assisted device, maybe not turning as quickly as you want to, but turning the way that your body can turn safely. And so that's really important. We also think about exercise as impacting our motor symptoms. So that's that stiffness or slowness or smallness of movement. But exercise can also impact our non-motor symptoms, like our symptoms such as issues with sleep or our memory, our thinking, depression, anxiety. All of those are shown to be improved with exercise. And so we think about what are our treatments for Parkinson's. We have our pharmacologic treatments. So that's the dopamine replacement medications. We have MAO inhibitors, which are stopping the dopamine from being taken into the cells. And then we have also like other extended release medications that will help. And a lot of those are created to help with the motor symptoms. And that's kind of what they help with. But we don't have a lot of non-motor or a lot of medications that can affect those non-motor symptoms. And so that's where the exercise comes into play. And so I really stress for an early assessment from physical therapy, occupational therapy, and speech therapy. I think that would be really good. And then our research also supports that. So that's where my decision come from.
Yeah, and that's something that they did bring out at the symposium on Saturday. That both Dr. Sutherland and I forgot the
Alyssa Cook, the speech
yeah,
therapist.
yeah, they were talking about the need for exercise, the importance of that. So when you get people that come in to you that have Parkinson's, what's one of the biggest? What are some of the misconceptions that people have about physical therapy when it comes to that?
Hmm. I think that one of the first ones is people think that, okay, she's going to make me go to the gym. And I'm like, no, first of all, I can't make you do anything. I can just highly, highly recommend you to do certain things, and especially to impact your health. But I tell people all the time, the best exercise program is the one that you will do. And if you're not going to go to the gym, well, then I'm not going to recommend that you go to the gym. I'm going to help tailor that exercise program to your needs, your likes, and also like, so there are people who hate exercise. Okay, fine. What do you like to do? Do you like to go gardening? Do you like to dance? Do you like to go kayaking? And so I'm going to recommend my exercise program based on what your habits are, what your hobbies are. And so I love to share that I'm a country line dancer. So I really enjoy dancing, and I will dance for 3 hours on a Friday night. And to me, that's so much exercise. I'm worn out after the end of it. That is like plenty. That's working on my balance. That's working on my turns. It's working on my stepping, my weight shifting, my cardiovascular endurance. And so I'm checking off all the boxes, but it's fun to me. And so I think that that's a huge piece. People think, oh, she's going to recommend I go to the gym, get on the treadmill, lift weights. And I'm like, no, we can find other ways to move well and that are going to help your body long term. And
Yeah,
then, yeah, I don't know. What do you think about that, Roger?
no, that's exactly right. I mean, we had our movers and shakers meeting yesterday at the Jack Randall Library, and we talked about exercise, and I made the point that the best exercise for Parkinson's is the one you're going to stick with. So whatever
Yeah.
that might be for you, line dancing, like you said,
Yeah.
kayaking, skydiving, mountaineering, whatever.
I'm thinking about the cardiovascular like challenge of skydiving.
Yeah,
It is
yeah,
a lot of adrenaline, maybe. I don't know.
yeah. I think it's just fearing for your life is probably the
Right.
exercise.
Yeah, another misconception that people have is that we only think about exercise, but really I have a lot of education and experience in health promotion and wellness. And so when we think about our body, the movements of our body, there are a huge impact based on our sleep, based on what we eat, what we drink, our water intake, our mental health, our social health. All of those aspects have a profound impact on our physical ability to move. So you think about, have you ever had a really terrible night's sleep? The next day, your balance is not as good. Or if you give your body food that is not fuel, it's more of just like lots of sugar, lots of fats, and it's not going to fuel your body to be able to move well. So I think, and I know that protein is like a really big issue because we have to, factor in a percent of people with Parkinson's will have that protein effect with the dopamine replacement. And so some of my people are like, wait, I can't get in enough protein. And I'm like, yes, you can. We just have to find a way for the timing to work. And also, you have to have protein to build muscle. You have to have protein for your body to be able to do things you need to do. So we have to find a way to make that happen. And so if I talk about nutrition because nutrition is an important piece. Now, I'm not a specialist in nutrition. That's the dietitian or the nutritionist. So maybe you need to have an appointment with an outpatient dietitian that can help you time your medications with your fuel. And so, but I need to talk about it because that's going to directly impact how your body can move. So I want to stress that total body wellness piece for everybody. And it's not just people with movement disorders. It's really anytime I'm trying to promote change in somebody's system, I need their health to be optimized.
Yeah, we have a lot of care partners on our group too, so that's something they have to think about too, is maintaining their own wellness, and that's a big piece of it. So a lot of times when people think of physical therapy, they think, oh, a person gets injured and it goes to the doctor, and the doctor says, okay, yeah, you hurt your shoulder, 4 weeks of PT, whatever. And most people don't think about going unless they do have an injury, but there's a lot of other things that we do annually. We go see our doctor, we get, cardiac tested, blood tested. How often should somebody that has Parkinson's see a physical therapist? Should they wait for their neurologist to make the call, or should that be something that they do annually?
So that's another great question. It depends on where you are at in your disease course as well, but I typically recommend every 6 months. So what I do with people when they come to see me, I will do an initial assessment. And my initial assessment is looking at their current level of function, their functional impairments that they have, so their difficulty performing their day-to-day activities, and then I look at their overall safety. And then I create a plan that can help to address all of those goals that were identified in the initial assessment. And so I'm working with people for a period of time. I help create the most important thing that I do is help to create that long-term wellness program activity plan. So a community-based program. And so once I have taught somebody all of the things that they need to know at that point, I will discharge them to their community program. And then I tell them, okay, come follow up with me in 6 months. So then they can ask their neurologist or even their primary care physician in 6 months, hey, can I go back and see physical therapy? And then when I bring them back in, it is what I call a tune-up. So just like you take your car to get its oil changed, I will do another tune-up assessment. So I do the same tests that I did 6 months prior, and I'm comparing those numbers. And so if I see that you've not had any change in the past 6 months, well, that's actually a good thing. And I say, okay, you don't need me. Go ahead, go out, keep doing what you're doing. Come back to me in another 6 months. But if I see that there have been changes, things that we need to work on, or emergence of new symptoms, well, then I create another plan to address those areas. And so I think that that is one of the best ways, because I need to make sure that you take some ownership of your health and your overall program. And I'm going to be more of a consultant, a facilitator. And so I don't want people to be over dependent on me coming back to see me like every month for the rest of their life. No, thank you. I need you to go and be out in the real world and living your life too. Because I tell people all the time, the physical therapy world is my world. The real world is your world. And I want you to go take the tools that we're learning in physical therapy and go apply it.
Okay, cool. Well, we live in a world where, change is very rapid. We talk a lot of times in our support group of cutting edge stuff that's coming up as far as Parkinson's, whether it's testing like with the biomarkers initiative by the Michael J. Fox Foundation or focused ultrasound, as opposed to DBS and different things like that. And of course, everybody's on the AI bandwagon now when it comes to artificial intelligence. So if you look into your PT crystal ball, what are some advances that you see coming down the pipeline, maybe that will be beneficial for the Parkinson's community when it comes to physical therapy?
Yeah, so going back to being an evidence-based clinician, I have to be on my toes in what is new, what is coming out. And so I take some of the new interventions and I determine, is this appropriate for me to apply it? And so I do like those randomized controlled trials or systematic reviews for me to be able to like put that research into practice. And so sometimes people will come to me and they'll say, okay, what do you think about this? And so I'll read the study and I'm looking at the study to see, is this appropriate for this person? Is this appropriate at this point in their disease course? And sometimes it's not. Sometimes it's, oh, this was a different type of inclusion criteria or a different type of people who are included in this study, and this doesn't apply to you. And so that's where the critical appraisal of the research is really important. But one thing that we need to determine as a profession is the proper dosage of therapy. And when I say the dosage, I mean how much, how often. And so there is a new study out of the University of Florida that is looking at the difference between burst physical therapy versus spaced out. So when I say burst, it's like that intensive short duration. So kind of like the LSVT big program. It's 4 days a week for 4 weeks. That is intense. It is short term. It is helping you a lot of repetitions. It has good research that shows that people will get better. Our flexibility gets better, our balance gets better, our gait speed gets better with that protocol. And so, but then there's also like an area of research that's supporting that spaced out, where it's maybe that person has physical therapy once every couple of weeks for a prolonged period of time. And so what we need to do is in that study from UF, I think there were only like 30 participants. And so I can't make my decisions based on a study that only had 30 participants. I need hundreds. I need lots of information in order and consistently showing those changes for me to implement that recommendation. And so that's what I'm hoping for maybe in the next couple of, it might take years for us to determine which is best, but then also it's probably going to be based on the stage of the disease that you are in, of this is recommended for this stage of Parkinson's, this is recommended for this stage of Parkinson's. And so that's kind of what I think about when I think about newer interventions. I mean, we have so many things like the treadmill training, robotic assisted training, we have virtual reality. I mean, there's so many things that are coming out. And so which is going to be the best? And that's what I need, that randomized controlled trial systematic reviews in order for me to make those decisions.
Yeah. Well, I tell people when I used to be an engineer, we had a saying in our department, in God we trust, everybody else provide data.
Yep. I like that.
I wouldn't believe what the engineers are telling me unless they had the data to prove it.
Yeah.
Yeah. And just a brief thing about the LSVT big. I remember when I first started my Parkinson's journey, that's what one of the very first things my MD said to try. And so my PT took a video of me walking around the parking lot before the 4 weeks and after, and the difference was just, it was like night and day. I went from looking like an 80-year-old to a 30-year-old. It was just an amazing program. I can't recommend it enough to people.
Yeah.
So what would be your one takeaway that you'd like everybody to come away with today based on our conversation about physical therapy and Parkinson's?
Well, I have about 5 takeaways, but we'll
Good,
see.
all 5. We'll take 5. We'll take 5.
Well, first of all, if you haven't been to see a physical therapist in a while, or if you've never seen a therapist, whether it's physical, occupational, or speech therapy, it's time to go. And so if you have a movement disorder, no matter what kind of movement disorder you have, it's time to get a check-in with a professional. And one of the best roles that we have is also taking that baseline measurement. So having numbers that we can then say, okay, this person is a fall risk, or no, this person's doing really well. I just need to tailor their exercise program a little bit to make sure that they can be safe in the future until they come back and see me in 6 months to a year. And so that would be my first recommendation. And I do want to just give a little shout out for occupational therapy. So a lot of people, like, they're like, what do they even do? And so our occupational therapists are specialty trained in being able to help with our day-to-day activities. But then our therapy team here at Sarasota Memorial, also we have therapists that specialize in treating visual issues. And we also have occupational therapists that can help with like returning to drive, and so there's a lot of skills that an occupational therapist has. They can help with the fine motor, they can give you strategies for managing with the tremor, like the recommendation somebody else had about using the electric razor versus like a standard razor, for safety. And so it's like, those little things that can make a big difference in your quality of life, and you didn't even know that it existed. And so it's like, oh wow, this can make a big difference. And so that's what I want to give that shout out for OT. And then for speech therapy, oh man, so many people come in and they're like, their volume is super low, and it's hard because with the Parkinson's you might not have any idea, because your internal calibration system is not working adequately. And so then it's like, my volume is fine, and their loved one over there is saying, no, I can't hear you, I have to ask you to repeat all the time. And so that is something that, it's sometimes hard. And then when we get into speech therapy, a lot of times they have like a biofeedback type of thing that you'll speak into a microphone, you'll get to see where's your volume compared to where it should be. And so that visual feedback is actually really awesome training. And then you can just bring that awareness. And then when you're out in a restaurant, your people will actually get to hear you. It's pretty amazing because your brains are fabulous and we want to hear what you have to say. So, and then also speech therapists can also help with swallowing dysfunction, and that's also kind of something that people don't think about, that it's an issue. But if you're drinking water and you're coughing, or if you're eating and you're coughing, it means that you're having swallowing dysfunction. And that's a big, big safety issue. You need to make sure you speak to your neurologist about it and help them get you into speech therapy. So that's one takeaway. Use your therapy team. Another takeaway is I really want people to participate in community-based wellness programs. So the Neurochallenge Foundation is amazing. It's got support groups, it's got classes for exercise, dance, it's got support for caregivers, it's got our expo coming up. I mean, any information that you want to get about managing your chronic condition, you can find. And so that's really great. And then in Sarasota County, we also have some other really amazing organizations. So connected with Sarasota Memorial Hospital, we have a gym. It's called Health Fit. And so we have a new program. Well, we're going to have Rock City Boxing coming up soon. We have PD Cycle, which is like pedaling for Parkinson's. That program is very similar. And then we have the Power Gym, which is an extension of the Power Moves program. So that's new that we have offering. And then in Sarasota County, we have Parkinson Place as well, another amazing organization that supports people with Parkinson's. There's other gyms that have Rock City Boxing. I mean, any type of activity program, like it's pretty much there. You just have to go find it. And so some people like are saying, well, I don't want to go out and be in in-person classes. Well, then a lot of the classes are offered on Zoom. And that's like one of the beautiful things that we have had from the COVID-19 pandemic, is that we offer a lot of exercise and support groups on Zoom, and it's great. But I also do like the idea of getting out, and even if it's not to an exercise class, maybe you go out and take a walk. So we have a lot of paved areas in downtown Sarasota by Marina Jacks, and then there's also a lot of state parks in our or county parks that have accessible pathways. And so I want to encourage people to get outside. I love getting outside and I love being outside, and so there's something about walking outside or exercising outside that can just like change your mood, change your motivation to exercise. I think it's very valuable. So get in with the community-based programs and get moving. I mean, exercise is medicine. I don't know if you've heard that before, but I hope you have. But when people come in, so I'm a doctor of physical therapy, I am writing you a script for your medication, and it's exercise. And so that's what I expect for you to do to manage your condition. So I really can't stress that piece enough.
Yeah, we definitely emphasize the proactive approach. I thought it was interesting you were talking about speech therapy, that Alyssa Cook's presentation on Saturday, she talked about silent aspiration. I had never heard of that before. I was like, wow, I didn't know you could aspirate without causing an immediate reaction. So like you emphasized, go to see a PT, see an OT, see an ST early, and get assessed often as you need to, so you can improve the quality of your life.
Yeah.
Thank you for sharing all that with us. And you also, she sent me a really nice PDF about Parkinson's and physical therapy from the Parkinson's Foundation. I'll include that insert in the follow-up email afterwards, but we'll open it up now to Q&A. So if you want, just either raise your hand physically or electronically, and I'll unmute you or ask you to unmute, and then we can ask Danielle a question. I'll start out with my buddy, Mark Spivak in the Caribbean. You have to unmute yourself, Mark. There you go.
There we go. Hi, Danielle. How are you?
Hi, Mark. I'm well. I'm not as good as you are, though.
It's a little rocky out today, but it's a sea day. We moved to CCR recently, and so they have a lot of different exercise classes and participated in them. I also have an exercise gym there, so I'm going there. But what you don't know is that last March I fell. Surprise, surprise. And I dislocated my shoulder and tore my rotator cuff. So I'm still under physical therapy for that. And that's life.
Yeah.
I'm over 20 years since my diagnosis, so I'm not doing too badly.
Yeah. Well, that's an amazing story, Mark. I mean, that's another reason that we want people to get in to see therapy is the incidence of falls is so high, and obviously
I kept track. I had over 60 falls in a month's period of time.
Yeah.
Wow.
And so at that point, it might be time to adjust the tool that you're using for getting around. And
I'm using a scooter now.
Yeah. And a lot of people have they have difficulty with using assistive devices because they don't want to be seen with an assistive device. And I've shared this before in other Parkinson's community presentations, but I see assistive devices as tools to be used at different times. And so there might be times when you need a walking stick. There might be times when you need a walker or a scooter or a wheelchair. But I think the goal is to keep doing things, keep being active. And if you need a tool to help you to accomplish that safely, then use that tool.
Like in the room here on the ship, I use the walker because the room's not big enough for a scooter, but when I leave the room, it's on the scooter.
You got a little horn on that scooter. You got to tell people, watch out.
Get out of the
way.
Thanks, Mark.
Thanks, Mark.
How have you been, Danielle?
Good. All right, does anybody else have a question they'd like to ask Danielle while we're here? Just like, I'll go to Russ. You have to unmute yourself, Russ. There you
I
go.
did it. I did it. I wonder if you could tell me a little bit. This particular therapy was recommended to me, not by a professional, just someone else. It's called neurofeedback training. And I don't really know a lot. I just started researching it. I don't, can you tell me anything about that, or is that?
No, I have no idea what they're referencing. I think that a lot of what we do is like providing feedback, whether it's I give people cues like verbally, or I'll give people what we could call like tactile cues, where I might put my hands on somebody to make a certain movement happen. But I'm not really familiar, Ross, with that type of training.
Okay. Yeah, it was sort of explained to me that you do it with a therapist. They put a cap on with little attachments to certain parts of
Okay.
your brain. And apparently, well, from what they're telling me, and I have to learn more about it, is that it helps direct or notify of the roadblocks. I don't know if that makes any sense. It's all new to me. But
Yeah, I mean, it sounds kind of interesting. It almost sounds like it's doing like a functional MRI, and not like an MRI, but it's determining that has anybody have like a nerve conduction study before, where it's like they kind of put needles in you and determine where's the nerve signaling going. So maybe that's what it is, where they're kind of trying to get the brain, the cognitive piece of I'm trying to make my foot move, and seeing, is that nerve actually firing to the foot? That's possible. I don't quote me on that though. So
yeah, that makes sense. And apparently there's a positive and a negative feedback that you experience as you're looking at the screen.
So that's, yeah,
I don't quite, but
biofeedback. Yeah, biofeedback is really common to be used. Like I was telling about the speech, where you speak into the microphone, it says, okay, this is your level of volume. And then, so maybe it's the same thing with your movements, where you move a certain way, your brain thinks you're moving it a certain way, but the amplitude of the movement is smaller because of the Parkinson's. And then you can kind of use that as feedback potentially.
thank you very much. That gave me more information, which is great. Thank you very much.
Yeah, let us know what you find out, Russ, as you try that.
Will. Thank you.
All right. Anybody else? Let's see, I'm missing hand. Rich, Katie, you got to unmute yourself. There you go.
Yeah. So I got a call from my daughter who lives in Costa Rica, and I had told her about being diagnosed with Parkinson's, and her friend Janine was visiting her, and it turns out Janine is a physical therapist in Salinas, which is, 30-minute drive from here. So she became my physical therapist. And you had mentioned that you should see a physical therapist a couple times a year. Can you explain why that is? I mean, I've been through a number of sessions. My garage is kind of set up as a gym. I have, weights and Peloton and, all kinds of stuff. So could you go into that a little bit more?
Wow, that makes me so happy. When I hear that people are following my recommendations, I'm like, yay. Okay. So what I recommend is and it always depends on the person. Obviously, it depends on where you're at in your disease. How comfortable are you with your exercise program? How comfortable are you with managing your and being aware of changes in your body? That's the piece that's why I would recommend like a check-in, a tune-up. And if maybe for you, it's once a year, if you feel like, okay, I'm pretty good, I'm moving well, I know when my body is not moving well and I know how to fix it. I know my own tools I have my own tools to fix it. That's fine. The only thing that sometimes people are, if you're not as familiar with your own body and the kind of the movement part of it, it's sometimes hard to determine, am I at risk for falls? And so if you went and had that assessment from your therapist and you're doing all the right things, your scores on your balance test were fabulous, your walking looked great, I'm not going to write up a plan of care. I'm going to say, okay, goodbye. Thanks for that assessment. We needed to do a check-in to make sure that you're all good, but then come back and see me in a year. That would be totally fine. But I would much rather you have that check-in than go and not really notice the change until it's like becomes an issue.
Thank you.
Okay, great. Thanks, Rich, for that question.
Yeah.
All right, who else had a question while I have everybody here? Oh, well, go ahead, Ken. You have to unmute yourself, Ken.
There we go. I have problems with balance, like many people, and the balance exercises drive me nuts. Trying to stand on one leg, I've tried to focus in on sort of almost a precursor to focus on the muscles that help you balance, rather than do the balance exercises. Is that a reasonable approach? Because I don't seem to get any good exercise out of, or any benefit out of standing on one leg when I can't do it for even 5 seconds.
Okay, so there's kind of a lot of pieces to that. So there is a principle of neuroplasticity that's called specificity, and that is train the specific activity that you want to improve. And so if you want to get better at your walking, then you walk. If you want to get better at playing the piano, you play the piano. And so that's where, if I want people to get better at their balance, I have them work on their balance. Now, there is a way I need you, when people are working on their balance, I need to make sure they have the just right amount of challenge. So if I give somebody and it's too hard and they're not able to do it for a prolonged period, then that's not an appropriate exercise. If I give somebody something that's too easy and they don't feel any kind of challenge, it's a waste of their time. And so with your therapist, you have to try and find that where, okay, my goal is to be able to stand on one leg for 10 seconds, but I can't get there today. How could I modify that so that I can work up to it? And so what I do with a lot of people is I have them put one foot on the ground and one foot up on like a step. And so then they have most of their weight on that one foot. The other foot is just kind of like a kickstand, like stabilizer. So that's one way that I will kind of take the exercise and make it just a little bit easier so that they can sustain it for like 30 seconds. That would be my objective.
That's great advice. That's great advice. I think that's a great idea.
All right, thank you.
As long as you're safe, whenever you're practicing your balance, I want you to be near a support surface. Don't do crazy things because Danielle said I could do it. So disclaimer.
There you go. Robert S., I think I saw your hand. It's going to unmute yourself. There you go.
Thank you. Yeah, I just wanted to, you commented that people don't want to be seen with the walking cane or right. I started sporting a walking cane pretty early on because I noticed that when I was walking unsteady or I was shaking, people were getting uneasy. You know, what's with him? Is he high on drugs or alcohol or whatever? So I used, although I didn't need it for balance per se, I used the walking cane as a signal to my fellow citizens. And that has worked very well because then you're not frightening. It's, oh yeah, he's disabled. So, you know, there's a category, he's not dangerous. Or not in a situation where, you know, there's something threatening or whatever. So that helped quite a bit to put everybody at ease.
Yeah, and I think too that when somebody uses an assistive device, it's almost like a signal to other people. Like you said, yes. Okay, this person might have a little bit of balance impairment. Let me give them a bit more space. So I don't know if you all have ever been in like Trader Joe's, or like, you know, we have a grocery store here called Detweiler's, and it's like there's a million people in a very small space. And so if you are walking and you have just a little bit of unsteadiness, but you're in a crowded place, somebody's going to bump into you, and then you might have a balance issue. But if you have an assistive device, it's kind of that signal that, hey, like, I need just a little bit extra space. Sometimes people hold doors for you. It's kind of nice. But
Okay, thank you. Edie, go ahead. If you unmute yourself, Edie. There you go.
I wanted to see if you could talk a little bit about insurance coverage. I think some people hesitate to go to therapy because it can be expensive. Most of us, I would assume, are on Medicare, and I know that Medicare pays for PT when there's an issue, a problem, an injury, pain. But how does it work with your, recommendation to do like a maintenance or management program?
that's a great question. So, and this is an area that our practice has changed a little bit over the past 10 years. So when I am working with somebody, in order for me to justify that I can continue working with them and that their insurance will cover my session, I have to provide skilled intervention that somebody lesser trained than I could not provide. So I know that was kind of like a mouthful, but if, say, I have already created an exercise program for somebody and I have nothing more to teach them, I cannot keep seeing that person just to run them through their exercises, because that's what a personal trainer could do, or that's what a, exercise scientist could do. But the physical therapist needs to be the person that's providing the skill of what a physical therapist does. And so that's where your therapist is going to determine that. And they're going to determine, okay, what kind of exercise program does this person need? What kind of training does this person need? And then I also bring the caregivers in to help train them so that they can help continue things at home as well. And so when your therapist is doing that initial assessment, it's their job to determine, can this be justified so that the insurance will pay for it? And yeah, financial burden is a huge piece. And so we want to be, as a professional, a healthcare professional, I want to be financially responsible in how I'm using the resources that the person has. So I can't see people, for 2 times a week for the whole year. That's not something that I professionally feel comfortable with, because I should, if I'm doing my job right, I should be teaching them what they need to do and sending them out.
Does that help answer your question, Edie?
Yes, thank you.
You're welcome. Okay, next is Pradeep. Go ahead, Pradeep.
Hi, thank you for the informative session. I have Parkinson. I was diagnosed 4 years ago, and I don't have tremors. Mine are mostly non-motor. But sometimes I see, if I do exercise, or I don't know if my anxiety is high, I have a little bit of shaking on my right leg, which I think I used to have before also. It just happens sometimes.
Mm-hmm.
What is it start of something worse, or just what?
I think that, so I go back to that being of a scientist and looking for patterns. So you've already identified a couple of patterns. So one is anxiety or nervousness makes tremor worse in all conditions. And so that's like a factor. I think that restless leg syndrome is also a common condition that people have, whether that is pre-Parkinson's, whether it's post-Parkinson's, whether it's just something that your body has developed. That's a factor. Or maybe it's fatigue. Maybe that fatigue is from exercise is then what kind of brings that tremor out a little bit more. And then another piece, it could be medications. So there's a whole laundry list of medications that people take that can result in like tremor. And so I think that obviously without like seeing you and seeing what the tremor looks like, it's kind of hard to just make that decision. But those are kind of the things that go through my brain when I have somebody with just a very rare tremor. I'm not as concerned about it unless it's impacting you functionally as well.
Okay, because my Parkinson is on the right side, and normally this tremor is, I think I never used to take notes, but I think it's mostly on the right side. Okay.
Yeah, it could be related to a change in the Parkinson's as well.
Okay.
Yeah.
Great.
Thank you.
All right. Anybody else have a question that they'd like to ask while we're here to have Danielle? I don't want to overstay or
I
stay
do.
welcome. Go ahead.
Hi, Danielle it is, right?
David.
Yes.
Following up on what Edie was saying, I have been in physical therapy over time, and what happens is the therapist has to show improvement, at least something, and when she does, you go, okay, well, I got to release you because they won't continue paying for it. So it's kind of a catch-22 situation. I understand
So
that you're showing that you are the only one that can show how to do this. So I guess I have to talk to my therapist about this.
yeah, so how to say this in a good way? Not all therapists are created equal. And so some therapists stay on top of the newer recommendations and some don't. Some therapists have to practice in a way that their clinic kind of determines that they can practice. So I know like my contacts at the University of Florida, they're recommending certain people are appropriate for this maintenance type of program. And there's some evidence to support it, but then there's also like resources at the APTA. So our American Physical Therapy Association has published like resources for therapists that they can go and get information about how do I assess somebody with maintenance being the goal, and how do I write up my goals, write up my treatment protocol. And so it would be kind of tough for you as the patient to come in and kind of tell your therapist like, here's what somebody else said that I need to be doing. And so but I want you to advocate for you, and I want you to get the best care. And so I think that if you could maybe ask them about it and just say, hey, have you heard about the maintenance recommendations from your professional organization for certain diagnoses? Maybe that's a question that will open up a conversation. And so if you do want to know more about it, you can go on the APTA. They have different education about different things. So yeah.
Thank you, Danielle.
Yeah,
You're welcome.
you're welcome.
And then like we talked about before, there is this organization called Synapticure. They offer all telehealth visits, and actually they do telehealth visits, including as part of your care team as a physical therapist, which is an interesting program. All right, anybody else looking for hands, either virtual or in person? Let's see, I'm just going to scroll through everybody's screens real quick. Daryl, go ahead, Daryl. You have to unmute yourself. There you go.
So I guess you probably help me even find what the question is and what to go through, but it's, where do you see that you fit in the Parkinson's treatment versus for progression? You know, are we slowing the progression? Is there any chance where we're reversing the whole thing? Or are we just doing some stuff to help with quality of life while the devil's doing his deed? Or, you know, where do you fit? And then it's also, how do you fit in the circle with the physicians who are, you know, you have to have a physician refer me to a therapist. One of my first things to physical therapy, where I was having some balance issues and a couple falls, the feedback from the therapist was, well, good God, your blood pressure is low and your heart rate's 42, and oh, it's because of the medicine you're on. Well, you need to come off of propranolol and get on something else to help with your tremors. So how does all that work for you? And like I said, where's the question in all that rainbow?
Well, I think it's a good question, and the answer is all of the above. So I think that when I am seeing somebody that is newly diagnosed, my role is a lot of education and teaching them about their condition, teaching them about what does our research say that they need in order to manage their condition long term, creating an exercise program at that point, and then sending them out to the real world. I expect people to get better sometimes. Unfortunately, a lot of times I get people and they've been diagnosed 3 years ago and they've never had therapy. And so when they come in to see me, I can make improvements because I can give them recommendations where they've never challenged their body in that way, or they didn't even realize that it was that difficult for them to get up out of bed. And so like I had somebody last week where it's like when they first came to see me, it took assistance from their wife to get up out of a chair in the waiting room. And then now they're able to pop up like no problem. And it's because of the training that we do and because of the work that they've put in. And then as your body changes, we will change our interventions that you need. We'll change our recommendations along with you. And so when I think about your team, obviously you're at the center of the team, of the wheel. Your primary care physician is also in there with you. Your neurologist is on your wheel. Your physical therapist, speech therapist, occupational therapist, neuropsychologist, there's your orthopedist, they're all a part of your team. And so in an ideal world, you have all of those team members that are going to hopefully work together. So I have a good relationship with the neurologist that I've worked with here. And it's just because I've been here for a long time, and I will say like, hey, like I need this for this person, or they might ask me like, okay, what do you think about this situation? Like, what do we need for this person? And so that's where kind of that team approach is really important for managing. And it's hard because not every system, you know, some people that live in the middle of nowhere, it's like, okay, I have to travel 2 hours to see a therapist that specializes in movement disorders. And so then you have to use maybe those virtual resources, maybe a little bit more. So.
Great, thank you.
You're welcome. All right, we got time for one more question before we let Danielle go. Let me just make sure I didn't miss anybody. I guess we got everybody. Okay, great. Well, thanks, Danielle, so much for coming. We appreciate you visiting our support group and for sharing all that wonderful information. And this video will be available probably sometime next week. And I'll include in the email later today the PDF that Danielle had sent me about physical therapy and Parkinson's disease that I think you'll all find informative.
And if you're in Sarasota County, make an appointment with Danielle for physical therapy.
Come see me.